We are ready to start the next session in the India's biggest medical PG prep academic event, the DAMS Visual Treat DVT 2023. But let us express our gratitude to all of you out there. And let's remember, the more we sweat in peace, the less we bleed in war. So all this hard work is going to pay us in the final exams. Next, we will be having the session on medicine recipe and ABG. And I'm sure that our esteemed faculty, Dr. Bharath Kathi, will provide valuable insights and perspectives on this important topic. Yes. Dr. Bharath Kathi is an MBBS graduate from SV Medical College, Tirupati, has done his MD Pulmonary Medicine from Kurnool Medical College, Kurnool. Also, he has a fellowship in Interventional Pulmonology, a fellowship in Allergy and Clinical Immunology, and a European Diploma in Respiratory Medicine. He has more than 10 years of teaching experience. Let's welcome Dr. Bharath Kathi for the topic Medicine Recipe and ABG Analysis. Over to you, sir.
Hello everybody. Good evening. I hope everything is clear and visible. As you all expected, I'll do as quickly as possible. Starting with the disclaimer. All cases or characters appearing in this work are entirely real. Any similarity to actual persons is purely intentional. If you want to get offended, you can get offended. No issue at all. So this is myself, a brief introduction. And shall we begin this show? Shall we begin this show, students? Yes, let's begin the show. Okay, are you all ready? Ready? Yes. Okay, starting with the clinical entities algorithm. So we have pulling lesions, pushing lesions, no push, no pull. So what are the pulling lesions that you know? So one is collapse and other is fibrosis. Collapse and other is fibrosis. No push, no pull, we have consolidation, whereas pushing lesions, there is pleural effusion, pneumothorax. I think yesterday you must have learnt about so much of push. So there is also a push in pulmonary medicine. It is nothing but pushing lesion. Then coming to the collapse, because there is no air, usually there will be a dull note. Whereas auscultation, because there is no air at all. So what will you find? Breath sounds are not there. So breath sounds will be absent here. Whereas chest X-ray, what will be the color of abnormality? So there is no air. So it tends to be white and it is no air. So it will be very white, homogeneous. Whereas fibrosis, because there is less air. See the difference between collapse and fibrosis. Collapse, no air, whereas fibrosis, less air. So the note will be impaired. Breath sounds will not be absent, it will be reduced. And less air is also white. But when compared to white of collapse, it will be less white. It is called white heterogeneous. Then consolidation, because of secretions, it will be dull. And what is the classical breath sound? Come on, answer. In consolidation, what will you listen? It is called as bronchial breath sound. It is called as bronchial breath sound. And on the chest X-ray, what do you notice? What is the classical finding? It is air bronchogram. It is air bronchogram. See, I am going to show you all these findings once again. Don't worry. Then pleural effusion, because it is fluid. If you percuss, you will get a very dull note called as stony dull note. Then because of the fluid acting as a barrier, breath sounds will be diminished or absent. On the chest X-ray, how will fluid appear? Fluid. It has to appear white because it is fluid within the pleural space. There will be a meniscoid fluid level. So it is white with meniscoid fluid level. Then pneumothorax. Yes, blockbuster note. If you percuss, hyper resonant, also called as tympanic note. Then auscultation. whenever there is too much of air in the pleural space, it will start compressing the adjacent lung. So air will not flow. So what is the breath sounds here? Diminished to absent. Then anywhere if you find excess air, it appears black. So it is hypertranslucent area with compressed lung margin, So these are the various differences. So collapse, if you are coming across, it is a pulling lesion. Think of white homogeneous abnormality. Fibrosis, pull, white heterogeneous abnormality. Then consolidation, no push, no pull. What you should see, air bronchogram. Pleural effusion, it is a pushing lesion, white with meniscoid fluid level. Pneumothorax, hypertranslucent area with compressed lung margin. Now everybody keep these findings in your mind. Now are you ready to recognize these on a chest X-ray? Are you ready to recognize these on a chest X-ray? Yes or no? Yes. Now tell me what is your answer. There is pull of trachea and you can see opacified right hemithorax. And the summary in the question given is there is absent breath sound with mediastinal pull to same side. So what should be your answer? What is this? White homogeneous pull. This is a right collapse. So here this is a right collapse. You should be right when you are thinking in terms of collapse. Then what is this? There is no push, no pull. And you can see branched airways. See here, I will focus it for you so that you can see it better. These are the branched airways, no significant push or pull, and clinically there is bronchial breath sound. What is this? This is consolidation. Then here you can see trachea is getting pushed and heart is also getting pushed. This is white and meniscoid fluid level, and you are having a stony dull note. What is this? This is right pleural effusion. Now somebody tell me why this is not collapse. Why this is not collapse? I am striking off collapse here. Why this is not collapse? Because collapse will also be white, homogeneous, but it will pull. This is push. So it is pushing the mediastinum to opposite side. Now coming to examiner's favorite. So if examiner wants to ask one X-ray from respiratory medicine, it will be this X-ray. What is this? This is black. And what else you can see? You can see compressed lung margin. And what is this? Shift of mediastinum to opposite side, because there is a black, there is a shift with compressed lung margin. This is left pneumothorax. So this is how we need to clinically and radiologically differentiate the common clinical entities in respiratory medicine. Then what is your diagnosis here? There is a patient with shortness of breath, underwent spirometry, and there is decreased FeV1 by FEC ratio. If this is the situation, what should be your suspicion? Yes, is it obstructive or restrictive? Obstructive or restrictive? Your answer should be obstructive. This is an obstructive pattern. And once again, students, whenever they give you any spirometry, first you should see the ratio. If you see the ratio, if the ratio is less, your answer should be obstructive. So the first parameter that you need to see is this ratio. You have to see this ratio. Now let me solve this for you. Very simple spirometry algorithm. See the ratio. If it is low, what should be your answer? Obstructive. If it is normal or increased, there can be two possibilities. What are those two possibilities? One, it can still be a normal lung, or it can be a restrictive lung. Now somebody in the audience answer. How is restrictive lung different from normal lung? Normal lung means small lung. Normal lung is normal lung, the normal size. Restrictive lung is small. So when do you call it a small lung? When FEC is less than 80%. By chance, if it is obstructive, next test, bronchodilator reversibility. If it is positive, what is bronchodilator reversibility? Positive disease. It is asthma. What is bronchodilator reversibility? Negative disease. It can be COPD. Whereas bronchiectasis is also obstructive lung disease. Its reversibility. In few diseases it can be reversible, in few it can be persistent. So generally it has variable. But definitely reversibility positive is asthma. Reversibility negative will be COPD. Then restrictive, again two types. If your lung is directly shrinking, it is intrinsic restrictive lung disease, or your lung is healthy. Something outside your lung is not allowing your lung to expand properly, such as your chest wall deformity, neuromuscular deformity. It is called as extrinsic restrictive. Very simple. Whenever they give you any spirometry, first see the ratio. If ratio is low, obstructive. If it is obstructive, bronchodilator reversibility test. If ratio is normal or increase, see the FEC. If FEC is low, it is considered as restrictive. If it is considered as restrictive, again in restrictive, are you dealing with intrinsic restrictive or extrinsic restrictive, depending on the history and other parameters. Then what is this respiratory failure? A patient with respiratory failure post-op, general anesthesia related. So whenever you give general anesthesia to the patient, you are completely knocking him out. After the patient becomes conscious, you should ask him to do some deep breathing exercises. Now instead of doing deep breathing exercise, if patient is busy sharing his post-op images as WhatsApp status, his lungs will not expand. And what is this? Post-operative lung atelectasis, general anesthesia related. Your answer should be type 3. This is a type 3 respiratory failure. So in your exam, they will be asking you type 1, type 2 are common in clinical practice, whereas type 3 and type 4 happens in special situation. So this type 1 respiratory failure is called as hypoxemic respiratory failure. So generally seen with severe pneumonia. These are the causes where there can be diffusion defect or decreased transfer of oxygen. It can be seen in ARDS. It can be seen in fibrosis. All that result in fibrosis, ILD. It can be seen in pulmonary embolism. Whereas type 2 respiratory failure, it is called as hypercapnic respiratory failure. Whenever somebody asks you regarding hypercapnic, remember the simple mnemonic COPD. Central cause, something happening at the level of brain. Hypercapnia means CO2 is increasing. CO2 will only increase due to two reasons. One, your brain stem is not working, no proper respiratory effort, or your airways are obstructed like this, not allowing the CO2 to escape. So central, especially something which will hit brain stem injury. O for obstructive causes. Common is severe COPD, chronic obstructive pulmonary disease. Peripheral, something happening at the level of your chest wall, especially respiratory muscle weakness. All those diseases we have known, such as polio, myasthenia, GBS. Then D for strongest respiratory muscle. It is your diaphragm. Is there any diaphragmatic injury? Whenever you are in doubt, what is the respiratory failure? Just see this COPD. If there is COPD, central, obstructive, peripheral, diaphragmatic, so it should be considered as hypercapnic type 2 respiratory failure. Now coming to type 3, this is perioperative respiratory failure due to lung atelectasis associated with general anesthesia. Whereas type 4, hypoperfusion of respiratory muscles in shock. So even your respiratory muscles require some blood supply. In shock, blood is not reaching your respiratory muscle, so they will not work properly. And the learning point here is, if it is general anesthesia related, post-operative, I mean within the operation theater or after the operation, it is type 3. Whereas shock related respiratory failure, it is usually type 4. So the peripheral is generally all this neuromuscular disorder, such as myasthenia gravis, Guillain-Barré syndrome, polio. Myasthenia Guillain-Barré syndrome, polio, all these are generally peripheral causes. So these are the usual types of respiratory failure. Type 1, type 2, type 3, type 4. Then what is this? A 30-year-old patient presented with features of acute pancreatitis. Few days later he developed dyspnea. And this is the chest x-ray. What do you see in this chest x-ray? Bilateral, top to bottom in all areas. So there are infiltrates. This is bilateral diffuse pulmonary infiltrates. So it is usually ARDS. What is the diagnosis? ARDS. Now somebody tell me, how can pancreatitis be responsible for ARDS? How can pancreatitis be responsible for ARDS? So whenever pancreas are damaged, so this from the damaged pancreas, so many bad substances will come into circulation. These substances from the circulation, they can go into the lung, hit the lung, damage the lung and result in ARDS. Now you only tell me, is it direct cause of ARDS or indirect cause? Generally acute pancreatitis is indirect cause of ARDS. What is the most common direct cause of ARDS? It is severe pneumonia. It is severe pneumonia. Now see here, let it be direct or indirect. ARDS is always a complicated phenomena, just like Salman Khan's relationship status. So we don't know what happens next. Sorry, who is next. Always a complicated situation is ARDS. Next, coming to what is the most important management in ARDS. Generally these patients presents to you with type 1 respiratory failure. Even if you give oxygen, there will be no significant improvement. Directly you go for mechanical ventilation. In the mechanical ventilation, most important, you should change one parameter. What is that parameter? Your answer should be tidal volume. So normal tidal volume, we keep it 10 ml per kg body weight. But ARDS lungs are very sensitive. I don't want the lung to break. So we give 6 ml per kg body weight. And these are the ARDS diagnostic criteria. Within 1 week, there can be shortness of breath. Chest X-ray can show bilateral diffuse pulmonary infiltrates. There can be non-cardiogenic pulmonary edema. So here it is non-cardiogenic. So if you see this chest X-ray, bilateral, top to bottom, side to side, in all quadrants you are having infiltrates. The end result is alveoli filling with some inflammatory exudate. So this is not due to left heart disease. So it is called as non-cardiogenic pulmonary edema. And PaO2 by FiO2 ratio, the criteria. So these are some standard criteria. You should know these numbers. PaO2 by FiO2 ratio will be less than 300 mmHg. So like I told you, make sure your balloon or your alveoli is not breaking. For that, apart from treating the underlying cause, most important is this range 4 to 8 ml, and the most important value is 6 ml per kg body weight. And give proper PEEP so that your alveoli will stay expanded and it will permit gaseous exchange. And other options available, we have ECMO, extracorporeal membrane oxygenation. And if ECMO is not available or patient is not affordable, you can go for prone mechanical ventilation. So in the ventilator, you have to set some tidal volume. So that tidal volume, normally we set it as 10 ml per kg body weight. But here we generally limit it to 6 ml per kg body weight. So other treatments, treating the underlying cause, glucocorticoids, all this can be helpful. Then what is this? Acute shortness of breath, hemoptysis, chest pain, hypotension, young female on OCPs. So you have to reduce. If you give too much volume, Ashish, if you give too much volume, your alveoli will burst. So this in combination with OCPs, your answer should be pulmonary embolism. So if you see this in combination in any exam, make sure it is pulmonary embolism. So this patient is in hypotension. So whenever there is hypotension, now what will become your full diagnosis? Massive pulmonary embolism is a possibility. Why I am very worried about massive pulmonary embolism? Because it has high chances of mortality. So whenever there is high chances of mortality, you should identify this immediately and treat properly. And usually in massive, the treatment of choice is thrombolysis. It is usually thrombolysis. So the answer here will be massive pulmonary thromboembolism, and this is patient will present with shock and RV dysfunction. Whereas when do you call it as submassive pulmonary embolism? The BP will be normal, but still there will be right ventricular dysfunction, and minimal might be a very small thrombus, normal BP and normal RV function. So the main treatment here, stabilize the patient, give anticoagulation, and most definitive, what should be definitely done? Your answer should be thrombolysis. If patient is not fitting for thrombolysis because of some bleeding, you can go for surgical embolectomy. Then if the patient is in submassive pulmonary embolism, so here main treatment is anticoagulation. If worsening, you should go for thrombolysis. How to check RV function? There is an instrument called as ultrasound probe. You can do echo, Prathamesh G. Tamber. So this can be known by doing 2D echo. Okay, you can check RV function by doing 2D echo. Then minimal will be normal BP with normal RV function. Here just anticoagulation will be sufficient. So these are the usual treatment options for pulmonary embolism. If patient is in a bad situation, initially you can stabilize the patient, start anticoagulation, but definitive treatment is always thrombolysis. Then a young female with unexplained shortness of breath, and there is high pulmonary artery pressure on 2D echo. No evidence of left heart disease or lung disease or connective tissue disorder, and there is also no drug, toxin related or genetic etiology. See, initially we give anticoagulation, we can start low molecular weight heparin. So what is this? So when there is high pulmonary artery pressures and you don't know what is the cause, it is called as idiopathic pulmonary hypertension. And in the classification there are 5 groups: group 1, group 2, group 3, group 4, group 5. This idiopathic right now is placed under which group? Anybody, which group? It is group 1. So group 1 is also referred to as pulmonary arterial hypertension. Okay. So this is idiopathic pulmonary hypertension. Whenever there is pulmonary hypertension due to lung disease or heart disease, main treatment is treating the underlying disease. When you don't know the exact reason, you should give drugs which will directly reduce the pressure in the pulmonary circulation. Now, how to give these drugs? First thing what you need to do is, you should put a catheter in the pulmonary artery and you should give inhaled nitric oxide. And you see the response of this pulmonary artery to this inhaled nitric oxide. After giving inhaled nitric oxide, if the pulmonary artery pressure is reducing significantly, it means it is a very good responsive pulmonary artery. No need to give costly medication. Basic medications will be sufficient. What is the most basic medication or very cheap medications? We have calcium channel blockers. So we do vasoreactive testing. How do you do? We give inhaled nitric oxide. After giving this, we assess the change. Reduction of MPAP. If it is more than 10 mmHg, it means it is easily responding. So you don't need to give costly medication. You give calcium channel blocker. Somebody might ask, calcium channel blocker. What is common calcium channel blocker that you give? Nifedipine. Then, if at all the fall is not significant, maybe it's only 5 to 7 mmHg, you should give costly medication. And this costly medication depends upon the severity. When do you call it as a bad patient? Class 4 New York Heart Association, shortness of breath. It means patient is having shortness of breath even at rest. Or is it non-high risk? Other classes, grade 1, grade 2, grade 3. Now if it is non-high risk, tablets will be sufficient. What is the most important tablet? It is ERA, endothelin receptor antagonist, such as bosentan. Or you can also add PDE5 inhibitor such as sildenafil or tadalafil. Now if this patient is belonging to high risk, bad situation, whenever a patient is belonging to bad situation, along with tablets, what else you will give? Injections. What is injectable treatment for pulmonary hypertension? It is epoprostenol. That is nothing but IV prostacyclin. So in very simple words, you do pulmonary vasoreactivity testing. After giving a single dose of inhaled nitric oxide, if the pulmonary artery pressure is significantly reducing, it is a well-responsive pulmonary artery, don't need to give costly medication. Simple calcium channel blockers will be sufficient. Now even after giving this, there is no significant fall. You stratify the patient. If he is a very sick patient, along with tablets, you give injections. If he is not so sick, only tablets will be sufficient. Most important tablet is endothelin receptor antagonist. So ERA means endothelin receptor antagonist. So it is nothing but bosentan or ambrisentan. So Pratyush Kumar, when IV epoprostenol is not available, you can also give inhaled iloprost, but generally in inhaled iloprost is not available in India. So if you are want to go to any US or UK, you can follow that guidelines. India, we have epoprostenol commonly. So how to check pulmonary hypertension? You put a catheter in the right heart. I think somebody is unable to see this word. So we have written right heart catheterization. Put a catheter in the right heart and you can measure the pressure. A patient with fever, cough and shortness of breath. So I think ERA, they are thinking some girl's name. Oh my God, it's not a girl's name. It is endothelin receptor antagonist. So it's not a girl's name. ERA. Okay, who will have a name called as ERA? It is endothelin receptor antagonist. Okay. Now is it clarified? No need to search in Google. No need to make her famous. Okay, done. Okay. A patient with fever, cough and shortness of breath. This is pneumonia. Okay. Then classification based on site of occurrence. So we divide it into community acquired pneumonia. If it is happening outside the hospital, medical facility. If it is within the medical facility, now the broad terminology is nosocomial pneumonia. So this community acquired pneumonia occurs outside hospital. Nosocomial pneumonia, again two types. If it is associated with ventilator, that too invasive mechanical ventilation, it is called as VAP. If it is outside the ventilator, it is called as simple HAP. So here the key word is 48 hours. 48 hours. Okay. Then coming to what is most common cause of typical pneumonia. Again, CAP in the community. Most common cause of typical pneumonia. What should be your answer? Streptococcal pneumonia. Streptococcal pneumonia. Whereas most common cause of atypical pneumonia, your answer should be mycoplasma. Your answer should be mycoplasma. Right now our Chinese neighbors are having mycoplasma pneumonia in excess. So you should know about mycoplasma. Then what is most common cause of hospital acquired pneumonia? If they ask you a group of organisms, it is gram negative. If they ask you a single organism, your answer should be staph. Then ventilator associated. Early VAP, it is simple organism called as Streptococcus. Late VAP, it is complex organism called as Pseudomonas. Again, for VAP overall also it is Pseudomonas. VAP overall also it is Pseudomonas. Now in the question, if they ask you, what are the causes of nosocomial pneumonia? See, it will be similar to VAP only, because whatever research we are having on nosocomial pneumonia is majority from VAP only, because VAP was dangerous. We did lot of research on VAP. So obviously whatever is common in VAP, it will also be common for nosocomial pneumonia. Once they have asked, early nosocomial pneumonia will be similar to early VAP. Late nosocomial pneumonia will be similar to late VAP. Then whenever they give you any pneumonia, see, common is Pseudomonas. Even Acinetobacter and staph can also happen. See, Acinetobacter is increasing these days, but in your books still it is there, Pseudomonas. So as long as you are writing an entrance exam, better to follow what is there in books. Overall for VAP, it is again Pseudomonas. So for assessment of severity, we use, it is CURB65. So C stands for confusion, U stands for blood urea. In international units, it is 7 millimole per liter, or in Indian units 40 mg%. See, early VAP within 5 days, late VAP more than 5 days. Done. Respiratory rate more than or equal to 30 per minute. Blood pressure, it is SBP less than 90 and DBP less than 60. And age more than 65. For all of this, we take 1 point into consideration. We take 1 point into consideration. So this is the scoring system. So if at all patient is having less score, less severe pneumonia, so we generally treat it at home. Whatever you do at home, it is called as outpatient or OP treatment. Now, if the score is more, you need hospitalization. It is called as IP treatment. IP means inpatient treatment. Inpatient treatment. So this is how you have to assess a community acquired pneumonia. He is coming to you. You see his curb 65 score. If at all it is not a bad pneumonia, you can prefer outpatient treatment. Again, if it is 2, hospital initially ward. If it is 3 to 5, we generally go for ICU admission. So less than 90. So Preeti Kumari, it is usually less than 90. I don't think in emergency situation you will be sitting and saying, oh, is it 90, 91? Usually less than 90 is taken. Okay. In few books, less than or equal to 90 is also taken, but that mild change will not be asked. Okay. Usually you keep it as less than 90 as standard. Okay then. Now usually NEET questions can be very traditional these days, very simple to understand, but there will be few examiners. They can also make NEET questions confusing. So let's, just like his dressing. So here I am confused whether is it his dress or his wife's dress. But always know that the concepts will always be very, very simple like this. Now what I am going to do is, I am going to introduce the concepts in a most simple manner, so that let it be a traditional question or let it be a confusing question, you are going to answer it properly. Now let us see the questions. Okay, starting with fever, red rusty sputum, lobar pneumonia. Quickly tell me, what is this organism? So this is a pneumonia happening to a segment. See, whenever somebody is having fever, patient will say, doctor, I am feeling heat in my body. Don't go and tell to the consultant, doctor, she is very hot. Once it has happened, my intern Kumar has come and told me that, doctor, she is saying she is very hot. Never use those. She say that there is some fever or she is feeling feverish. So fever, red rusty sputum, lobar pneumonia. What is this combination? It is streptococcal pneumonia. Streptococcal pneumonia. And what will be your treatment? It is beta-lactam. So fever, red rusty sputum, lobar pneumonia. It is streptococcal pneumonia and treatment is beta-lactam. Then this one, fever, red currant jelly sputum. And what is this? Normally your horizontal figure should be straight like this, but it has bulged down. This is called as bulging fissure sign. Bulging fissure sign. You can see the fissure, it has bulged down. If you see this in combination, what should be your suspicion? Come on, what should be your suspicion? It is Klebsiella pneumonia. It is Klebsiella pneumonia. And what are the treatment options? We generally give beta-lactam with aminoglycoside. See the difference. In lobar pneumonia, the fissure will not bulge down like this in classical streptococcal pneumonia. So this is also involving a lobe, but the weight of Klebsiella pneumonia is very high, so that fissure will bulge down. Then, oh my God, cruise ship travelers enjoying their cruise, but after contaminated water, diarrhea, pneumonia combination. What is this infection? Frequently asked, what is this infection? This is Legionella. Legionella. Somebody has spoiled their vacation. Legionella is a big spoiler of vacation. So what will be the treatment? So best will be respiratory fluoroquinolone. You can also give azithromycin. You can also give azithromycin, or you can also give tetracycline. But here beta-lactams, because of some unknown reason, will not work. Beta-lactams will not work. So beta-lactams such as amoxiclav, ceftriaxone. Somebody is asking names of beta-lactams. So beta-lactams, because of some unknown reason, will not work. Okay. So important drug will be fluoroquinolone. Next, fever, dry cough, hemolytic anemia. So very important. Pneumonia, diarrhea combination. It is Legionella. This pneumonia with hemolytic anemia. What should be your answer? Your answer should be mycoplasma. See, mycoplasma can trigger cold agglutinins in the body, and it can cause hemolytic anemia. And what is the treatment? Who is the drug of choice for myco? It is macro. Who is that macro? Azithro. So azithro is the primary drug. And next, you can also give fluoroquinolone. You can also give tetracycline. But here you cannot give beta-lactam. Now tell me why you cannot give beta-lactam. Because this is not having cell wall. This mycoplasma is not having cell wall. So beta-lactams are not going to work. Not going to work. Yes, this is also called as walking pneumonia, because generally it is a mild pneumonia and the patient is not taking bed rest. He is walking generally. It was called as walking pneumonia. Next. Well, who is he? Here there is a truck driver with fever, with GMS positive ball. Now what is this pneumonia? VIP, very important pneumonia. Who is this organism? Who is this organism? It is pneumocystis. Pneumocystis. GMS positivity. NEET 2023 question. And tell me students, what is the drug of choice? It is cotrimoxazole. Cotrimoxazole, also called as Septron. Trimethoprim sulfamethoxazole. So if you find truck driver, most probably his occupation, he might have some HIV with GMS positive ball. So there can be pneumocystis. So this is GMS is specific for pneumocystis, and treatment for pneumocystis is generally cotrimoxazole. Cotrimoxazole. Then travelers with fever, with shortness of breath, with anosmia. Anosmia, loss of smell. Loss of smell. What is this infection? It is SARS-CoV-2. SARS-CoV-2. It is nothing but your COVID-19. So severe acute respiratory syndrome causing coronavirus. See, mostly the elections are next year. I feel you will not find any questions regarding COVID, because our government wants to make us forget that COVID has happened in our country. But still, what is new in COVID? Nothing is new in COVID. The same old thing. I'll just give you a brief update. So what is it diagnosed in COVID? It's not CT chest. It is not blood test. It is usually swab test. You should send the swab for RT-PCR. If somebody asks you, out of nasal and throat swab, which is most important or which is highly sensitive, it is nasal, and it should not be taken like this. If it was taken like this, we boys will be doing only that duty. So thank God it is not taken like this. And treatment. In India, the main treatment is usually, yes, SARA. SARA is not actually Sara Ali Khan, but once for a good reason, remember Sara. S stands for steroid. A stands for anticoagulation. R stands for required oxygen and proning. And A is antiviral called as remdesivir. Out of all this, which is most important drug? Which is most important drug? Your answer should be steroid. So steroid is the one known to decrease mortality in critically ill patient. So Bhupraj Janva, anosmia is caused by COVID-19 infection because it involves the nose. Nasal epithelium is involved. So transiently smell function will reduce. Okay. This steroid is the one known to decrease mortality in COVID-19. Mortality in COVID-19. So the name of the trial is recovery trial. Recovery trial. Okay. Now, you all are asking about Lord Bobby. So this is for all of the fans sitting there. So this fellow is an alcoholic. Purulent sputum. Chest X-ray is showing. Chest X-ray is showing there is a cavity. There is a cavity with air and there is fluid. This is, what is this? What is this combination? Come on everybody. See, what I am trying to establish here is, in exam, everything will be dependent on these keywords. You will be seeing an alcoholic with some history. He is having this much amount of age. He had breakup. He was going here and there, taking this brand, that brand, and later having foul smelling sputum, and chest X-ray was taken. You would see this. See, the main thing is, all that rubbish you leave. Only these keywords. Alcoholic, purulent foul smelling sputum, chest X-ray, air fluid level. What is this? This is lung abscess. See, I have to appreciate this fellow. He is the only one who is marrying twice or thrice happily. So once itself is very difficult. He is the real animal. He is marrying happily thrice. So then, okay, leave that. That is something personal. So lung abscess. What will be the drug of choice? So organism here in alcoholics. Aspiration, oral anaerobes, oral anaerobes. So for oral anaerobes, your answer should be clindamycin. Your answer should be clindamycin. See, once again, students, this is an examiner's favorite question. So there will be foul smelling sputum, chest X-ray showing the air fluid level, and he is an alcoholic. Aspiration history will be given. So it is a primary lung abscess. Lung abscess divided into two. So a primary lung abscess, it is mainly due to aspiration. And because it is due to aspiration, organisms will be those in the oral cavity. They are oral anaerobes. Secondary lung abscess, it is due to some pre-existing lung disease. Already there might be a pneumonia. That might complicate into lung abscess. Say for example, Pseudomonas, Staph, Klebsiella. But examiners favorite will be primary lung abscess. Primary lung abscess. Yes. So that's why I never tell my wife when I'm going to a class. Okay. So yes, pneumatocyst. See, what I'm trying to do here is only the main aspects I'll cover. See, pneumatocyst can also be seen, but pneumatocyst will not have that fluid level. Okay. Then coming to a 55-year-old with SOB and following chest X-ray. So what do you see in this chest X-ray? Come on, students. I'll be very happy if you label this chest X-ray. So there is a tracheal shift. Your heart is extremely towards left. And you can see on the right, whitish abnormality with meniscoid fluid level. Okay. So this is a pleural effusion. This is a right pleural effusion. Whenever they give you any pleural effusion, what they are going to ask you? The diagnosis based on analysis. So that analysis you can easily do with Leit's criteria. Based on the Leit's criteria, you should divide it into transudate, exudate. Whenever it is transudate, life is very easy. Why? Because most of them are systemic causes. What are the systems responsible for transudative effusions? 3 systems: your heart, your liver, your kidney. Most common is heart disease, cardiac failure. And what is the kidney disease responsible for transudative effusion? Nephrotic syndrome. And whenever there is a liver disease responsible for transudative effusion, it is called as hepatic hydrothorax. It is called as hepatic hydrothorax. See, all these slides will be given as annotated PDF. Kindly follow me. I have a lot of content, and if you permit me, I'll also share my humor with you. Only thing is, I need your cooperation so that to make it more entertaining and productive for you. Now, if it is exudate, having an exudative pleural effusion is always having an X, always painful in your life. So what pain it will cause? It can be due to multiple. So why will somebody become X to you? It will not be a one reason. It will be multiple reasons. In the same way, just like a breakup, just like having an X, exudative pleural effusion have multiple issues. Number 1, it can be due to malignancy. You should send it for cytology. Gram stain. Why you should send it for gram stain? To check for any possibility of infection. So that hepatic hydrothorax is generally usually due to cirrhosis only, dude. Student, it is due to cirrhosis, any liver disease. Then TB markers. Why I should send it for TB markers? Because right now, TB is most common cause of exudative pleural effusion worldwide. TB is most common cause of exudative pleural effusion. Tell me 2 markers. Apart from lymphocytes, what else will be elevated in TB? ADA, more than 40 international units. Interferon gamma, more than 140 picogram. See, as long as you are in India, you should remember about TB because it is our national disease. If you don't remember, I will label you as anti-national. So that's why it is lymphocyte rich. ADA more than 40 international units. Interferon gamma more than 140 picogram. Whenever there is TB inflammation, all this tend to increase in your body. Then where can you see low glucose pleural effusion? Usually in empyema. There is a lot of pus. Pus contains bacteria. What do they consume as food? Glucose. Malignancy. Malignant cells, they consume glucose. In rheumatoid arthritis, just like arthritis, as a part of pleuritis, what will happen? Pleural inflammation. And that inflamed pleural cells have high metabolism, and fuel for that metabolism is again glucose. High amylase pleural effusion, pancreatitis, esophageal rupture, and malignancy. Coming to high lipid pleural effusion, because of the lipid content, the pleural effusion tends to be white. There are 2 important lipid pleural effusions. Number 1, chylothorax. So whenever your thoracic duct is breaking because of some surgery, chyle will start accumulating within the pleural space. What does chyle contain? Triglycerides. So important feature here will be pleural triglycerides. Value will be more than 110 mg. And another lipid pleural effusion is pseudochylothorax. So pseudochylothorax is due to unnecessary accumulation of cholesterol in long-standing effusions. Long-standing effusions such as TB effusion and rheumatoid arthritis. So if at all, RA means rheumatoid arthritis. RA means rheumatoid arthritis. So if at all examiner wants to ask in pleural fluid analysis 1 question, it will be definitely from this table. First assess, are you dealing with transudate or you dealing with your X called as exudate? If it is transudate, life is very easy. If it is exudate, it is very difficult. These are the things that you need to, know for your exam. Then coming to classification and stepwise therapy of stable asthma. Classification and stepwise treatment. For asthma, actually there are 2 medications. What will control asthma or what will control inflammation? It is inhaled corticosteroid. Who is boss for asthma? The mega star for asthma is steroid. Then reliever medication. Whenever patient develops sudden symptoms, you should give something immediately so that he will be surviving. So that reliever medication, according to new guidelines, it is combination. So when you were seeing Cartoon Network, it was Saba. But right now, after advent of GeoSim, I'll not tell what you have seen midnight. Even you don't think what you have seen midnight. Now the new generation follows low dose inhaled corticosteroid. Low dose inhaled corticosteroid with formoterol. Okay. Now coming to why we are not using Saba these days. See, Saba is just like using a single arrow to target multiple aspects of the disease. Now in asthma, it is not just bronchospasm. It is inflammation related bronchospasm. It is inflammation related bronchospasm. If you just give Saba, inflammation is not coming down. Now to cover everything in a disease, now this Saba is replaced by this blockbuster combination. Now there are multiple arrows targeting all aspects of the disease. What will ICS target? Inflammation. What will formoterol target? It is bronchospasm. That's why in community, if any asthmatic is developing acute symptoms, what should be immediately given? You should give combination. What is this blockbuster combination? Inhaled corticosteroids with formoterol. So this is a recent update. Okay. Then stepwise management, track 1. See, track 1 means we are following the new guidelines. Track 2, especially poor countries who cannot afford this costly combination, they can follow this Saba directed therapy. So India is a rich country. Why I say India is a rich country? Within country we have Ambani, Adani. Outside country we have Nirav Modi, Lalit Modi, and also Vijay Mallya. All rich people are there within country, outside country. So India is generally considered as a rich country. Moreover, in our country, getting all these inhalers is easy. So track 1 means we are using the new guidelines. Then coming to how do I actually treat an asthma patient when he comes to my clinic. So first I will assess the symptoms. Is it infrequent symptoms or frequent symptoms? Frequent symptoms means generally daily symptoms. Infrequent symptoms means once in a while. Suppose once in a month. Symptoms less than 2 per month, or symptoms more than or equal to 2 per month, or up to 4 to 5 days per week. So it is alternate day symptoms, students, not daily symptoms. So frequent symptoms are those with, so for all Rishi Sunak fans, I have something special for you, just wait. So frequent symptoms, most days, nighttime awakening, more than or equal to 1 per week. So what is nighttime awakening? Nighttime awakening is sleep disturbance due to asthma. Then we have daily symptoms or nighttime awakening more than or equal to 1, and low lung function. Low lung function, FEV1 less than 60% of predicted. You have done a PFT and his FEV1 is less. FEV1 is less. Now according to patient symptoms, we are going to adjust the treatment. So if patient is having less symptoms, lesser step of treatment. If patient is having more symptoms, higher step of treatment. How I am going to adjust? Now see here, for this we give step 3, this step 4, and beyond that we generally give step 5. So coming to, let it be at any step, we give if there is acute symptoms, as needed rescue medication. Yes, please stop discussing all anti-national issues in the chat box, please, or else I'll not tell you any jokes today. Now what did Zina do? If at all patient is not having daily symptoms, no need to give daily medications. So for step 1 and step 2 together, now only on the day of symptoms patient can use this medication. So as needed, low dose inhaled corticosteroid with formoterol. Now from step 3 onwards, patient is having daily symptoms. So daily you should give combination. What is this combination? Low dose inhaled corticosteroid with formoterol. From step 4, you give medium dose. So medium dose inhaled corticosteroid. So generally dose of corticosteroid is not asked for your level, but generally there will be few students who wants everything about everything, and lastly they will not do anything. So for them, low dose means 200 to 400 micrograms of budesonide equivalent per day. Medium dose is 400 to 800 micrograms of budesonide equivalent per day. High dose is more than 800 micrograms of budesonide equivalent per day. So 200 to 400, 400 to 800, more than 800. Then coming to step 5 students, step 5. So in step 5, we can add extra bronchodilator called as LAMA. So it is tiotropium. Then consider high dose inhaled corticosteroid. HD means high dose inhaled corticosteroid. See, safest drug in asthma is anything that saves the patient's life. If it is not about the safety of the drug, it is safety of the patient. If patient requires ICS LABA, if patient requires SABA, don't worry about safety. Because if you worried about safety, patient may not be there to think about safety next time. So in emergency, give SABA in emergency department, salbutamol. In community, budesonide with formoterol you can give. Okay. Then coming to refer to specialist center, still not improving. And you can consider for biologic treatment. So biologic treatment are all those costly antibodies. So in step 5 means even with step 4 patient is not improving, students. With step 4 patient is not improving, then you think of step 5. What are the other options available? See, other options available from step 2 onwards, you can give anti-leukotrienes immunotherapy. At step 5 as an optional therapy, you can do oral steroid. In the old guidelines, oral steroid was directly placed in this box. Now because of side effects, oral steroid is kicked out from the box. It is an alternative therapy or optional therapy. Or you can also start azithromycin. Azithromycin is having both anti-infective and anti-inflammatory properties. It might be helpful. So in step 1, step 2, only on day of symptom patient should take, not daily. From step 3 onwards, patient should take daily medication. Now what are the costly biological treatments available? Blocking antibodies, anti-IgE, omalizumab, anti-IL-5, mepolizumab, and we also have reslizumab. Now suppose, see, daily therapy means morning, evening, rescue therapy. In between patient develops any symptoms, immediate therapy. So maybe patient has done afternoon some dusting, morning she has take medication, evening also she will take. But in between if she develops any symptom, what should be immediately given is rescue medication. Okay. Now suppose they give you a question like this. There is a 25-year-old beautiful female coming to your hospital with shortness of breath. You have diagnosed her adequately as asthma. And you have prescribed her on step 3 treatment. Daily morning and evening, you asked to take medication. In between required, take medication. And she was affordable. You have given anti-leukotrienes and you discussed 2 hours with her regarding immunotherapy that you never do with your male patients. After 3 days, she returns back to your clinic, throws inhalers on your face, telling that your medication is not working. What will you do next? What will you do next? See, whenever a patient is not improving with a given step, what will you do next? So most of you think it is stepping up the treatment, but in asthma, before stepping up the treatment, what should we immediately do? See, rescue medication is nothing but low dose inhaled corticosteroid. Same thing we have discussed. See, even after seeing Bahubali movie, you are again asking who is the hero and heroine in Bahubali. I have showed you now. Now rescue medication is low dose inhaled corticosteroid with formoterol. So make sure whenever a patient is not improving at a given step, make sure she is using her inhaler properly. See, most important in asthma management is not giving costly medication. Make sure she is using inhaler properly. Second thing in asthma is, because these patients have lot of triggers, make sure they are controlling all those triggers. So 2 things apart from giving inhalers that you should see in exam is, 1, they should also control those triggers, because asthma is a disease with so many triggers. So use the inhaler properly, control the triggers, and then the asthma will get controlled. Then coming to the next disease. What is this disease? Smoker related. So this is gold guideline COPD. So for your exam, they will generally ask you the grading. So when do you call it as gold 1? Mild COPD, moderate, severe, very severe, or commonly used gold 1, gold 2, gold 3, gold 4. So you should know if FEV1 is more than or equal to 80% of predicted. So that is referred to as gold 1. Gold 2, FEV1 in the range of 50 to 79%. So this is 30 to 49%. Less than 30. So previously asked question. Which of the following qualifies for very severe COPD? Your answer should be FEV1 less than 30% predicted. So in the question, if you notice, patient's FEV1 is less than 30% of predicted. So this is called as gold 4, very severe COPD, very severe COPD. Then coming to the COPD treatment algorithm, it is based on a graph. So on the graph, on the horizontal axis, there is patient symptoms students. So we divide the symptoms into less symptoms, more symptoms, means more grade of breathlessness. So we use a scale called as MMRC, Modified Medical Research Council. And on the vertical axis, we use patient's exacerbation history in last 1 year. Last 1 year, how many times patient has worsened. And with this, we divide patient into less exacerbations, more exacerbations. Now with help of a line, I have divided exacerbation. See here, with help of a line, we have divided exacerbation. With another line, I am going to divide the patient's symptoms. Now if you notice here, initially we are having 4 groups, A, B, C, D. But many studies have shown that this C and D are actually having same natural course and same prognosis. So there is no point in classifying them into C and D. So they have merged them into a single group called as E. So now it is COPD A, B, E assessment. So now in the older textbooks, it is COPD ABCD. Now in the newer textbooks, your guidelines, it is COPD A, B, E assessment. What is the treatment that you give? For A, it is bronchodilator. For B, it is any bronchodilator you can give. SABA you can give, SAMA you can give LAMA, LABA. Whereas B, it is always combination. It is always combination. E, you can start with combination, LABA plus LAMA. And if at all history of asthma is there or eosinophils more than 300 mm3. So maybe patient in childhood had asthma, later smoked, developed COPD, or indirectly by eosinophil count. Here you can give triple combination. So what is the triple combination? LABA, LAMA, ICS. So this is the final treatment in generally COPD. So in inhaled medications I am seeing. So this is a triple combination, LABA, LAMA, ICS. Okay. So B is LABA plus LAMA. B is LABA plus LAMA. Done. See, gold grading is not for giving treatment. So it has been changed. For giving treatment, we only give this. So that is just for trial purposes to know how did the patient present to you at the beginning. So after giving treatment, has he improved at least some? So more than 300 you can take in COPD. Then coming to Aspergillus related lung disease. So MMRC is Modified Medical Research Council. It is a breathlessness scale. So for ABPA, we have type 1, type 3, type 4 hypersensitivity. So this is a hypersensitivity reaction due to Aspergillus. And what are the important features? So we have predisposing factors such as bronchial asthma, cystic fibrosis. Then skin test will be positive to Aspergillus fumigatus. Then what about the IgE levels? Because this is type 1 hypersensitivity, IgE will be significantly high. And in the body, there will be presence of Aspergillus specific IgE and IgG. This is more of your body is not liking Aspergillus. It is giving an hyperimmune response. That hyperimmune response is called as ABPA. So in the CT chest, what do you notice? CT chest is proximal or central bronchiectasis. Proximal central bronchiectasis. So what do you see? Suppose there is a bronchi and you are having your trachea here, and if there is bronchiectasis happening in bronchi very nearer to the trachea, it is called central or proximal bronchiectasis. Now tell me, what is the most important treatment? This is a hyperimmune response. Star will be steroid. So primary treatment here will be steroid. Along with that, itraconazole, simple antifungal, can be given to reduce the frequency of exacerbations. Now coming to invasive pulmonary aspergillosis. So whenever patient's immunity is less, immunocompromised, it causes an aggressive pneumonia. So it has a transbronchial angioinvasion. They'll ask you, what do you see in active phase, recovery phase? So in active phase, there is something called as CT halo sign. I will show you in the CT. Recovery phase, air crescent sign. And the treatment is generally oriconazole. So what is the treatment here? Your answer should be oriconazole. So this is a aggressive pneumonia. So you should give something which will bring down the fungal population. Aspergilloma, there is a cavity. In that, fungus will settle down with its family. So what is this family business called as? Aspergilloma. And what are the radiological signs? So we have monad sign. So this is just colonization, not invasion. So if the patient is standing erect like this, fungus will be here. If it turns to this side, fungus will come to this part of the cavity. If it turns to this side, fungus can come to this part of the cavity. If you take a chest x-ray in each position, you will see ball changing its position with decubitus. So here treatment will be resection. Okay. See, the main treatment in ABPA is not voriconazole, is not itraconazole. Main treatment is steroid. Okay, steroid. See, what you are doing is, what is main, you are not focusing. What is accessory, you are fighting. Yes, peripheral eosinophilia will be seen in ABPA. It is written. What else you need? Okay. What do you see here? Central portion white. Peripheral portion less white. Presence of a less white area around white area. It is called as CT halo sign. CT halo sign. Somebody is asking me to drink water. So I don't waste water, okay. I drink something after the class that I don't want to tell you now. So summary, there is organ transplant patient with history of fever, shortness of breath and hemoptysis. So what is this? This is CT halo sign. So what should be your answer? Active phase of invasive pulmonary aspergillosis. Active phase of invasive pulmonary aspergillosis. So this is classical CT halo sign. This is classical CT halo sign. Then you have given treatment. Later you are seeing air like a half moon shaped structure. Half moon shaped structure. This is recovery phase. Recovery phase of invasive pulmonary aspergillosis. Recovery phase of invasive pulmonary aspergillosis. Okay. CT halo sign, you can see here. Central portion is white because of fungal inflammation, and peripheral portion there is blood that will cause GGO. So it is less white. Center white, peripheral less white. This phenomena is called as CT halo sign. Allergic bronchopulmonary aspergillosis. See, I actually kept my brand in lung abscess photo that you have in your book. So recovery phase of invasive pulmonary aspergillosis, air crescent sign. Okay. Then this is a female with poorly controlled asthma. This female's asthma even God cannot understand. Throughout the year she will be smoking. Only on day of festivals she will come with inhaler. Okay, leave it. So you are having high serum IgE, more than 1000, poorly controlled asthma. And on the CT scan you can see central bronchiectasis. Central bronchiectasis. Okay. So this is ABPA. So allergic bronchopulmonary aspergillosis, ABPA. ABPA, allergic bronchopulmonary aspergillosis. Then what is this? Known case of pulmonary TB, chest X-ray is taken. And what you notice here, there is a cavity, because pulmonary TB generally will host a cavity. In that cavity, there is a fungus, and above that air can be seen as a half moon shaped structure. This is called as Monad's sign. And what is this disease referred to as? Aspergilloma. Once again, students, they will ask you how well you can differentiate invasive pulmonary aspergillosis, allergic bronchopulmonary aspergillosis, aspergilloma. The names are very similar, but the content is very different. See, they sound the same. So just like both Sunny Deol and Sunny Leon will be shouting in their movies, but the reason and the context is very different. So don't get cheated by names. Be always thorough with the contents of what you are going to see actually. Such confusing diseases are invasive pulmonary aspergillosis, allergic bronchopulmonary aspergillosis, aspergilloma. So whatever I have given in that table, kindly keep it in your mind. One question is definitely asked. Then female residing in coastal area. So in coastal area of our country, yes, nighttime cough, wheeze, chest X-ray infiltrates, high eosinophil count. See, already the slides are there in your DVT book. Just give me some more time. Okay. This is a tropical pulmonary eosinophilia. Then why this is happening? Especially in our country in tropics, within the lymphatics, there will be Wuchereria bancrofti and Bruguea malayi. So these worms are going to produce microfilaria. Your lung is not liking that microfilaria. It gives an extreme hypersensitivity reaction. That extreme hypersensitivity reaction, what is it called as? It is called as tropical pulmonary eosinophilia. So what is this relevant exposure in endemic area? See, I generally combine education, entertainment, so that you will not forget. So if you don't want any entertainment, I'm a very, very serious guy. So you can have it. From next onwards, I can also be very serious. Okay. So here there will be more of nighttime symptoms. So why nighttime symptoms? Because the worms will be more active in the night. They will be producing more larvae into the night. And many kind of infiltrates can happen. You can have an unilateral infiltrate, bilateral infiltrate. Then guideline says that in this disease, eosinophilia can be noted more than 3000 per mm³. Very high eosinophilia. And see here, relevant exposure. In our country, where was tropical pulmonary eosinophilia commonly seen? Coastal area, in the coastal belts. Okay. And in them, if you find high eosinophilia, nighttime symptoms, chest X-ray infiltrates. So this is a type 1 hypersensitivity. So serum IgE will be elevated, antifilarial antibodies will be elevated. So you should suspect tropical pulmonary eosinophilia, because this was given in NEET 2021. So don't forget, when there is eosinophilia, endemic area, and chest X-ray infiltrates, nighttime symptoms, one possibility tropical pulmonary eosinophilia. And drug of choice is DEC, diethyl carbamazine. Drug of choice is DEC. See, in ABPA already patient will be having asthma, and typically central or proximal bronchiectasis will be there. And in ABPA you find Aspergillus specific IgE. So final diagnosis for ABPA is Aspergillus specific IgE. That you don't find it here. You find here antifilarial antibodies. Then bird lovers were there. They developed, somebody playing with birds, shortness of breath, cough, chest X-ray infiltrates. But eosinophil count is normal, IgE is also normal. So when you see this situation, so exposure to birds, each time they get exposed to birds, they are getting symptoms. So this is also appearing like an allergy. But classical allergy generally will have high eosinophils and IgE. So this is mediated by type 3 and type 4 hypersensitivity. What is this entity called as? Anybody? This is called as hypersensitivity pneumonitis. So this is not an infection. This is an allergy, extrinsic allergic alveolitis. So psittacosis is an infection. Each time they go to a bird, they will not get. Here each time they go, they will complain. So once they are withdrawn from it, they will be fine. And it will not present like an infection. It will be a recurring episode. So predictive criteria. Number 1, history of exposure to known antigen to cause HP. So HP is hypersensitive pneumonitis. Pigeons, very, very dangerous. So in our country, pigeon exposure, allergic symptoms, rule out hypersensitivity pneumonitis. So apart from pigeons, moldy hay, farmer's lung, sugarcane dust, bagasosis, all these are part and parcel of hypersensitivity pneumonitis. Especially the 1990 Bollywood heroines were living in a very dangerous environment. 1, they were exposed to pigeons. 2, they were exposed to somebody whom I will not say who is that. But that was very dangerous than pigeons. Your body is not liking antibodies. So it produces, your body is not liking this antigen. It produces antibodies. Precipitants means antibodies. So this is a type 3 plus type 4 hypersensitivity. Whereas asthma is type 1. ABPA is also having type 1 predominantly. Then these patients generally have 4 to 8 hours after antigen exposure, and there is recurrence. Each time they are getting exposed to this, they are getting symptoms. And because of continuous exposure, continuous symptoms, they may not take diet properly. Weight loss was also noted. So treatment, if you are not liking pigeons, don't go and play with this substance. So this is also considered as an abnormal inflammatory response. To bring down that inflammation, we are going to give steroid. Okay. See here, other diseases which come under hypersensitivity pneumonitis. So for you, apart from bird fancier's lung, farmer's lung, bagasosis. Okay, this is due to sugarcane dust. So these were asked. This is due to moldy hay. This is due to sugarcane dust. So bird fancier means who is playing with birds, fancying birds, who breed the birds. Okay. So psittacosis is an infection. Each and every time he go to it, there will not be that thing. So Shivam, Naval, Kishore, Asava, psittacosis, you get it today. Once you get treated, after 10 days you will not get it. But this one, each and every time you go near it, you will get it. Yes? Okay then. So farmer's lung, moldy hay. Bagasosis due to sugarcane dust. So there are also other things, but this is commonly asked. Then a 60-year-old male is referred for dyspnea on exertion, chronic cough. On auscultation, bilateral inspiratory fine crepitations are heard. So this is an ILD, but elderly chronic symptoms. So elderly chronic symptoms, and in the CT scan you can see abnormal rounded areas of hairs called as, it is honeycombing, and also there is traction bronchiectasis. If you see this in combination, it is UIP. When you are unable to tell the etiology, it is called as IPF. UIP means usual interstitial pneumonia, and you don't know why this has happened in this patient. It is called as IPF, idiopathic pulmonary fibrosis. See, nowadays what has happened is, whenever we show honeycombing, people will start getting confused with crazy paving. See, actually honeycombing and crazy paving is not difficult when compared to below differentiating. So these two people, I always find it very difficult to differentiate. But honeycombing and crazy paving are very clear. See here. In honeycombing, why it is happening? Around the alveoli, there is lots and lots of fibrosis. So the alveoli are getting compressed. So still in that alveoli, there will be air. You will notice some black areas. Whereas in crazy paving pattern, within the alveoli, excess surfactant is getting filled. Any area of less air or no air should be white. So alveolar filling will have white, that is crazy paving. Whereas honeycombing, still you can see that blackish areas called as abnormal air filled areas. Now see here. Now you only tell me, A, B, who is your honey, who will make you crazy? So which is honey, which is crazy? Now you only differentiate. Let me see. So in honeycombing, still you notice you notice abnormal rounded areas of air because it is nothing but compressed alveoli. A is a honey, B is somebody who drives you crazy. So both should be there in your life. There should be somebody called as honey, there should be somebody who is driving you crazy. So both should be different or your life will be plain. So honeycombing and crazy paving. So never get confused with this. Okay. Then finally putting out the differences. So this clinical presentation, usually UIP, elderly, males more than females, chronic symptoms, smokers, fine crepitations, clubbing. So I'll just read out the symptoms and I'll tell you how to remember it in a very easy manner. Biopsy, bad areas of fibrosis called as fibroblastic foci are there. So radiology, bilateral lower zone, minimal GGOs, and because this is having lot of fibroblastic foci, lot of fibrosis. If there is a fibrosis, there will be honeycombing. There will be honeycombing because it is honeycombing. Treatment generally is not proper. See, already advanced form. Usually the prognosis will be poor. And whatever tablets we are having, perfenidone, nintedanib. So all this cannot stop further progression. They will only, they can only cease for a while. But finally, even if you give these tablets, it will progress. Only for a while they can halt. And if they ask you what is the best treatment available, it is only lung transplant. Then NSIP. This is mostly seen in middle age, females more than males, non-smokers are involved, subacute presentation. Because here the bad findings called as fibroblastic foci are rare. So the bad findings called as honeycombing will be rare. Mostly it will be a good finding called as ground glass opacity. And because it is only a good finding, steroids will be sufficient. Now see here, whatever worst happens in UIP. Now see, being elderly is bad. Being a male is very, very bad in this society these days. Having fibroblastic foci is bad. Having honeycombing is bad. Whatever worst happens to him. Him is male and him is honeycombing. Now see here. Whatever good happens here. Middle age is good. Being a female is good. Having less fibroblastic foci is good. Having ground glass opacities is good because it is only mild haziness. Girls, ground glass opacity, good prognosis. Him, honeycombing, bad prognosis. So we are always unlucky. So UIP, unfortunate him, male, honeycombing. Whereas NSIP, good, girls, and ground glass opacity. So this is the final difference. Okay. Then what is this? So this is just mild haziness, but in crazy paving pattern, same ground glass opacity, you will have a typical pattern like this, just like a pavement. Here you don't see that typical pattern. Now what is this? So this is subacute symptoms, restrictive pattern, ground glass opacity. So this is nothing but non-specific interstitial pneumonia. Then what is most common ILD pattern routinely? Which pathology? Because it is happening usually, it was called as usual interstitial pneumonia. Usual interstitial pneumonia is most common pattern. But in connective tissue disorders, it is NSIP. So most common overall is usually UIP. Because it was happening usually, it was called usual interstitial pneumonia. Whereas most common in connective tissue disorders is NSIP. But one exception. In rheumatoid arthritis, it tends to be UIP. So these are few exceptions. Overall, because it is happening usually, it was called usual interstitial. Connective tissue disorder, it is NSIP. Connective tissue disorder, it is NSIP. Whereas in rheumatoid arthritis, it is UIP. It is UIP. Okay. What is this? A construction worker with shortness of breath and following chest X-ray. So here you can see areas of pleural plaques. So this is a pleural plaque, calcification on the diaphragm, and you can see fibrosis. See, upper zones are not involved, construction worker more in the lower zones. So this is typical of which condition? So this is your asbestosis. So this is asbestosis, lower zone fibrosis, asbestosis. Okay, done. We'll do it fast. So then what is this? Quickly tell me. So number one, this combination is Lofgren syndrome. There is hilar lymph node enlargement, polyarthritis, erythema nodosum. This combination is called Lofgren syndrome. Number two, within the bridge of nose, areas beneath eyes and cheeks. This is not rash. Mostly you will have painful nodules. This is lupus perineo. What is number three? Uveo-parotid fever. So here there will be uveitis, parotid enlargement, fever and facial nerve palsy. So this put together, it is nothing but sarcoidosis. So when you see any of this, it can be possible sarcoidosis. It can be possible sarcoidosis. So let it be Lofgren syndrome, let it be lupus perineo, let it be uveo-parotid fever or Hereford syndrome. See these manifestations, it can be sarcoidosis. Then three occupational lung diseases are very important. We have asbestosis. The main findings, there can be pleural plaques, pleural effusion, lower zone fibrosis. See, asbestosis is having lower zone fibrosis. So in this, most common is silicosis. Silicosis and coal workers will have more in the upper zones. And what is the most common malignancy associated with asbestos? It is still lung cancer, that is adeno. Most specific is mesothelioma, and there is also another radiological finding in asbestosis called as round atelectasis. Whereas silicosis, it is more in the upper zones. Initially there will be nodules. Later they can merge to form progressive massive fibrosis. So in silicosis, the infection is generally tuberculosis. Silica particles can damage alveolar macrophages. Alveolar macrophages, first line of defense against TB. Then you can notice an important finding, bilateral hilar lymph node enlargement with eggshell calcification. With eggshell calcification. Then coal workers pneumoconiosis, more in the upper zone. And initially, the silicosis findings and coal workers pneumoconiosis findings can be very similar. Only difference is the occupation. So initially upper zone lesions. Later they merge to form complicated coal workers pneumoconiosis. Exposure to coal, inhaled smoke can also cause COPD. And in coal workers pneumoconiosis, one thing you should know, there is something called as Kaplan syndrome. So this is rheumatoid arthritis with pneumoconiosis. They can say that this patient has exposure to coal, now has joint pains and shortness of breath. So the point here is this inhaled particles, they not only cause lung disease, they can also trigger some autoimmune events. So this Kaplan syndrome can also be associated with silica exposure, but first identified with coal. So point to know here is asbestosis is predominantly lower zone disease. Silicosis, coal workers pneumoconiosis will be predominantly upper zone disease. Now what do you see here? There is a 50-year-old male stonemason. What is stonemason exposed to? He is exposed to silica. And in the upper zone, you can notice some densities. In the upper zone, you can notice some densities. Then, what do you see here? Here also, upper zone dense nodules are seen. But if you keenly see here, surrounding fibrotic areas are noticed. See, such dense nodular fibrosis in a patient with silica exposure should give you possibility of which condition? Your answer should be progressive massive fibrosis. It is due to silicosis. So upper zone nodules will be there. Upper zone nodules will be there, and these nodules along with fibrosis, it is called as progressive massive fibrosis. This combination. So previous slide. This is this slide. Okay. So asbestosis, mesothelioma, adenocarcinoma, lower zone. Silicosis, upper zone. Kohlberger's pneumoconiosis is also upper zone. Kaplan syndrome, rheumatoid arthritis with pneumoconiosis. Now coming to examiner's favorite. See, examiner's favorite is not that person. He was a plumber by occupation. And on the chest X-ray, you see pleural opacity without mediastinal shift. So whenever there is any pleural opacity or any pleural space occupying lesion, it should cause a push. But here there is no push. The reason is, especially in asbestosis, when there is a mesothelioma. Mesothelioma is a pleural tumor. Already in that lung there is fibrosis. Fibrosis pulls. This will push. Fibrosis pulls. This will push. So both can cancel each other. So the mediastinum will not be shifted. So this is very important. Pleural opacity. Pleural opacity without mediastinal shift. Without mediastinal shift. So this combination can be mesothelioma. Mesothelioma due to asbestos exposure. See, why I am calling it as examiner's favorite is, in NEET 2023, they have asked, there was a patient with mesothelioma. What is the occupation? Asbestosis. A patient shipbuilder. On X-ray there was pleural opacity without mediastinal shift. What can be the possibility? The answer was mesothelioma. So this is a very, very trending question. So that's why I call it as examiner's favorite. So don't search for that person in Google today. Then stone crusher. Stone crusher. Yes. What happens in stone crusher? Again silica exposure on the CT chest. You can see crazy paving. So in that movie later he becomes an head crusher. See the diagnosis when there is milky ball. So this stone crusher can be exposed to huge amounts of silica. Silica particles damage the alveolar macrophages. So alveolar macrophages are responsible for surfactant clearance. Now surfactant is not cleared properly. So there will be increased surfactant in alveoli. So why there is no shift? See here. Already in asbestosis lung there is fibrosis. Fibrosis will pull. Whereas this mass will push. So when there are two mutually opposite things, they can cancel each other. So that pull and push can cancel each other and the mediastinal position will remain neutral. So if you see this in combination, surfactant is a whitish colored substance. Surfactant is a whitish colored substance. So you will find within the bronchoalveolar lavage white. And what is the treatment generally? It is whole lung lavage, putting a bronchoscope and removing all the surfactant. Excess surfactant. Yes. So this is pulmonary alveolar proteinosis. Then see, a patient with excess daytime sleepiness, obese snoring. So for your kind information, that is not called as domestic violence. If it is opposite, it is called as domestic violence. Now see here, whenever they give you any PSG finding, only two things you see. How is the airflow? How is the respiratory effort? So here there is no airflow, but still there is persisting respiratory effort. If you see here, after some time respiratory effort is also increased. So no airflow is apnea and there is respiratory effort. It means your brain is working well. As long as your brain is working well, it is not central sleep apnea. It is obstructive sleep apnea. Now in the question these days they are asking, obstructive sleep apnea with hypercapnia, advanced form, it is called as obesity hypoventilation. Now if the patient becomes too much obese, lot of fat in his abdomen will not allow him to breathe properly because he is unable to breathe properly. So his respiratory effort reduces. So oxygen will not come inside, CO2 will not go outside. So it can cause CO2 retention, hypercapnia. So if you see here, if you see this obstructive sleep apnea with reduced respiratory effort, it is called obesity hypoventilation. Sleep apnea syndromes divided into two. Central, because of some unknown reason your brain is not working properly. So it is not giving signal to your respiratory muscles. So there will be no respiratory effort, no airflow. So the exact mechanism is not known. It was observed in congestive heart failure and narcotic use. In obstructive sleep apnea, no problem in your brain. Because of some reason, your upper airway is closed, maybe due to obesity. and because his brain is working, there will be persisting respiratory effort, and in majority it is obesity related. See, whenever there is CHF, maybe the circulatory delay will be there. It may not reach your brain properly, so that the signals may not be given properly. Exact mechanism is not known. Okay. Then what is this? Anybody? Yes, what is this? See again, see the flow. There is no flow, and if you see the movement is also not happening. So this is a classical central sleep apnea. This is a classical central sleep apnea. Okay, this is a classical central sleep apnea. Now what is this? A patient with lung cancer with shortness of breath and dilated veins. See here, there is dilated neck vessels, chest vessels, and swelling. So this is a classical feature of SVC obstruction. And what is the most common cause of SVC obstruction? Small cell lung cancer. So whenever your superior vena cava is blocked, students, because of malignancy, so there will be backflow of blood. Because of backflow of blood, yeah, there will be neck swelling and dilated veins over chest wall. Then in lung cancer, 3 are very important: adeno, squamous, small. I'll tell you how to remember in a very simple manner for your exam. Adeno is generally most common type worldwide. It is peripherally located. If you see female, non-smoker and asbestos, think of adenocarcinoma. Adenocarcinoma is the one with highest incidence of clubbing. And in malignancy, apart from direct manifestations, the tumor cells produce few substances and give few indirect manifestations. That indirect manifestations also you should know. What are those indirect manifestations called as? Paraneoplastic syndromes. Adeno is famous for Troche syndrome. Adeno is famous for Troche syndrome. Now whenever they say squamous cell carcinoma, you should know 4 C's. What are those 4 C's? Yes, what are those 4 C's? Anybody? It is centrally located, cigarette smoking, cavity formation, and it causes a paraneoplastic syndrome with respect to calcium. So this hypercalcemia is most important paraneoplastic syndrome of squamous cell carcinoma. So this was again asked in NEET 2023. See, most of you think getting complicated question right is great. It's not like that. You should not miss a easy question. So nobody expects you to do wonders. Make sure you will not avoid blunders. So that is the main essence of life. So even if you mark a very rare question correct, if you mark a wrong question wrong, a common question wrong, there is no point. So this is a commonly asked question. So the name is small, but it can cause all manifestations. What are all those manifestations? So it can be centrally located, associated with smoking, It can cause rapid recurrence and metastasis. See, I don't think so much is left. I know how much is left. You are thinking so much is left. Okay, no problem. So I am going at a pace so that you can understand. There is no point if I just read out. You can just employ a newsreader rather than me. Okay. So rapid recurrence and metastasis. Then it is highest associated with superior vena cava obstruction. Then there are so many paraneoplastic syndromes associated. So the unique selling point, USP of small cell carcinoma exam question is paraneoplastic syndromes. So there is hyponatremia, hypokalemia, hypocalcemia. So all these hypos are caused by small. Hyponatremia due to syndrome of inappropriate ADH. Hypokalemia due to ectopic ACTH. See, tumor cells are producing all these substances excessively. Now see here, students, how to remember this. If you notice here, hypo. Hypo means less. Small means also less. So this is very key. All the hypos are caused by small cell lung cancer, whereas hypercalcemia is a life-threatening complication of squamous cell. This you should know. Majority of hypos are caused by small, whereas hyper is a life-threatening complication of squamous. Now let us see a few important questions. Now you only answer. Now let me see how quick you are in answering this. Smoking. First question. Smoking. There is cavity. There is hypercalcemia. What is the lung cancer? Your answer should be squamous. Squamous. Okay. Then smoking, central location, SVC obstruction, hyponatremia. If you see this in combination, it is small. It is small. Okay. So this is the classical presentation. Smoking, cavitation, hypercalcemia, squamous. Smoking, central location, SVC obstruction, hyponatremia, it is small. So what are these manifestations? This is called as clubbing. Initially the problem was here, then here, now here. It is migrating. This is called Troche syndrome. If you see this in combination, what is the suspicion? Your answer should be adenocarcinoma. So this is a classical example of adenocarcinoma presentation. So what is this? There is Horner syndrome. You can see ptosis and meiosis. So tumor in the lung apex. So in the lung apex, whatever tumor is there, common these days is squamous, later adeno. Any tumor in the lung apex, it is called as Pancoast tumor. That Pancoast tumor can locally extend and cause few direct manifestations. See here, there is a tumor in the lung apex. It can extend upward and block the stellate ganglion, resulting in Horner syndrome. It can extend outward and it can damage first two ribs, resulting in destruction of first two ribs. It can also extend posteriorly, C8, T1, T2, and it can result in pain initially, later weakness in ulnar distribution. A tumor in the lung apex called as Pancoast tumor can cause all these manifestations. These manifestations put together, they have given a special name. What is that special name? Pancoast syndrome. Once again, existence of tumor in the lung apex, it is called as Pancoast tumor. And all the manifestations put together, it is called as Pancoast syndrome. See, lung cancer is a examiner's favorite topic because so many questions are given. I will consider this as a special topic. And kindly know this, students, whenever there is a special topic in exam, you should make sure you are knowing the direct manifestations definitely. And along with direct relationship, you should also know the indirect manifestations. They are more commonly asked. Like for this person, here this is direct relationship and he is indirectly related and famous. So don't ask me how these two are indirectly related. I will not utter the word on live TV right now. So for any special topic in medicine, know how they are directly related, also know how they are indirectly related also. Okay. So lung cancer is such topic in respiratory medicine. Definitely a question will come and your strike rate should be 100. Then coming to ABG interpretation. So I am going to conclude in, say I started 6:20. I'll make sure I'll complete at 8:20. You don't worry. Coming with the very simple words. See here. Respiratory acidosis. You know CO2 is acid, bicarbonate is base. So pH is reduced. To call it as respiratory, CO2 should be elevated. Whenever there is acidosis, your body always fights with alkalosis. If it is primary respiratory, it fights with metabolic. So this is a reflex defense mechanism happening in all of us. And because of that, there will be metabolic alkalosis. Now see here, to call it as alkalosis, pH will be elevated. When do you call it as respiratory alkalosis? CO2 washout will be there. And for respiratory alkalosis, how will your body fight? Metabolic acidosis. Then to call it as acidosis, pH should be reduced. To call it as primary metabolic, bicarb is the one reducing. So when there is metabolic acidosis, your body will fight with respiratory alkalosis. So to call it as alkalosis, pH is increased. So why here pH is increased? Because of increased bicarbonate. And to fight against this, CO2 will also increase. So the first rule is, whenever it is a primary respiratory disorder, change in pH, with respect to parameters generally will be in opposite direction. But if it is a primary metabolic disorder, change in pH with respect to parameters will be in same direction. Let me show you this so that you will understand. So I'll take two disorders commonly as respiratory acidosis, metabolic acidosis. So the parameters that I am going to see, pH, PaCO2, bicarbonate. Okay, pH, if it is reduced, to call it as acidosis, decreased pH is acidosis. To call it as primary respiratory disorder, where the change should happen, CO2. What is respiratory acidosis? CO2 increase. For respiratory acidosis, what should be the compensation? Metabolic alkalosis. So bicarb will increase. This is how primary respiratory acidosis behave. To call it as metabolic acidosis, pH should reduce. To call it as a primary metabolic event, you only tell me where that ball should roll onto. It should roll onto bicarb. So bicarb decreases metabolic acidosis. As a compensation, there will be respiratory alkalosis. Once again, you only see in primary respiratory disorder, change in pH with respect to parameters opposite. Here they will be in same direction. Even if you forget this logic, don't forget this mnemonic called as ROME, Rome. Because whatever ABG questions they have asked, it was only revolving around this concept. They'll ask you what is the primary disorder, is it acidosis or alkalosis? So ROMB, respiratory, it is opposite, metabolic, it is same. Now this is a question, you only draw arrow marks. See normal pH 7.35 to 45. So I'll just write down pH 7.35 to 7.45. CO2 take it as 40. Bicarbonate 24 to 26. Now just to draw arrow marks. If you see here, pH is reduced, CO2, bicarbonate increased. This is acidosis. Change is in opposite direction. So it is respiratory. Now if you notice, everything is in same direction. Decrease in pH is acidosis and the change is in same direction. So what should be the name? Metabolic. And apart from this, all the compensation formula practice questions you can see in 616. So whatever is required for ABG questions per se, I have given in a single PDF all the formulas, simple disorder, mixed metabolic with clear explanation. Just go through once, it will be sufficient. Then anion gap is defined as the difference between sodium, chloride and bicarbonate. So high anion gap, normal anion gap, metabolic acidosis will be there. So when will anion gap increase? Whenever directly acid is added to your body. What are the conditions when acid increases in your body? Unnecessary production, either diabetic ketoacidosis, lactic acidosis. Acids formed in your body not going out. When will they not go out? Renal failure. And any alcohol can get converted into aldehyde, aldehyde to acid. Can you tell a drug which is acid? It is salicylate acid. So here all acid addition will result in high anion gap metabolic acidosis. Normal anion gap, it is not due to any acid addition, just loss of bicarbonate. So it can be a pancreatic fistula, ureterosigmoidostomy, diarrhea, loss of lower GI secretions. Your lower GI is filled with bicarbonate. So diarrhea generally causes metabolic acidosis. Aldosterone deficiency, renal tubular acidosis. Then coming to metabolic alkalosis, again divided into two. If it is responding due to saline, it is saline responsive. If it is not responding due to saline, saline unresponsive. So whatever metabolic alkalosis happens due to volume loss, it can trigger renin-angiotensin aldosterone system. That is the cause of metabolic alkalosis. If you give saline, it will replace the volume. And in this, commonly asked is, they'll give you a lot of history. Vomiting will be there. Finally, they'll ask you, what is the acid-base disorder? So your answer should be metabolic alkalosis. See, your upper GI secretion is pulled with acid. So whenever somebody vomits out, acid will come out. When acid is lost, what will your body develop? Metabolic alkalosis. Saline unresponsive, primary aldosteronism, Cushing syndrome, renin secreting tumor, Bartter syndrome, Gitelman syndrome, Liddle syndrome. So in your exam, they are not going to ask you the mechanism. They'll just give you this name and they'll ask you whether it is saline responsive, unresponsive metabolic alkalosis. So anion gap normal value is 8 to 12. Now coming to next infection, see here. COVID is bad, but TB is its dad. COVID only 3 years, TB since 3000 years. Previously it was only drug sensitive TB. Now it has become drug resistant TB, very difficult to handle. Now in a nutshell, see here. Now TB, there are no categories. There is nothing like 1, 2, 3, 4 categories. So drug sensitive TB, new case, old case. It means it is rifampicin sensitive TB. So here the treatment will be 2 HRZE plus HRE. So no way we are giving streptomycin routinely here. Drug resistant TB. We have H. H means isoniazid resistant TB. I think you know what is H. Isoniazid, R rifampicin, Z pyrazinamide, E ethambutol. Then we have MDR TB. MDR TB means resistance to both H and R. There is XDR TB. XDR TB is extensively drug resistant. See, right now K is not included in anion gap, students. K has been removed. So this is MDR TB that is resistant to, see here the definition. XDR TB is MDR TB that is resistant to fluoroquinolone. Along with fluoroquinolone, in group A drug, it should be resistant. It can be bedaquiline, linezolid or both. So fluoroquinolone resistance is mandatory. Along with that, either bedaquiline or linezolid or both. Now if it is an MDR TB only resistant to fluoroquinolone, it is called pre-XDR. Along with fluoroquinolone, other drugs is called as XDR, extensively drug resistant. Now see the difference here. In H resistant TB, because H is not working, you remove H. And 6 to 9 months, we give levofloxacin, rifampicin, pyrazinamide, ethambutol. Levofloxacin, ethambutol, pyrazinamide, rifampicin. So this is the primary treatment. Now coming to the regimens, I'll just put it here. I'll give you some explanation. For MDR TB, right now we are using 2 regimens, a longer regimen, a shorter regimen. Longer regimen is usually for 18 to 20 months. Shorter regimen is usually for 9 to 11 months. So longer regimen, these are the drugs: bedaquiline, clofazimine, cycloserine, linezolid, levofloxacin. See, it is very humanly difficult to remember these drugs if you are not treating the patient. But somehow for your exam, you have to keep mnemonics and remember. Whereas for shorter, it is 9 to 11 months. It is bedaquiline, high dose isoniazid, ethionamide, levofloxacin, ethambutol, clofazimine, pyrazinamide. Okay, these are the various drugs. So when you can go for shorter regimen, when there are no exclusion criteria. What are the exclusion criteria? When it is a bad disease, shorter regimen will not be sufficient. When is it called as bad disease? Extensive TB, severe extrapulmonary TB, such as miliary TB, CNS TB. Shorter duration will not have any benefit, or any drug in shorter duration not working in this patient. Either there is resistance, intolerance or previous exposure, or isoniazid resistance with both genes. If one gene is there, you can think of giving high dose isoniazid. Children below 5 years, not yet licensed. Lactation, not yet given. But in pregnancy, shorter regimen can be given. Now coming to the WHO update. WHO has told that for MDR TB, you can go to a 6 to 9 months BPAL regimen. Whereas pre-XDR TB, you can go for for MDR TB, you can go for BPAL-M regimen. Whereas in pre-XDR, where you cannot give fluoroquinolones, you can go for 6 to 9 months of BPAL regimen. But this is not available in our country as of now. So the 2 new regimens is, if patient is having MDR TB, you can go for 6 months of BPAL-M regimen. If it is pre-XDR in the sense, you cannot give fluoroquinolones, you can give BPAL regimen, 6 to 9 months of BPAL regimen. So all the regimens, I have put it in a nutshell. So BPAL means B for bedaquiline, PA for pretominid, L for linezolid. So here is the full form. M stands for moxifloxacin, B for bedaquiline, PA stands for pretominid, L stands for linezolid, and M stands for moxifloxacin. Now, if it is only a plain XDR TB, in our country the treatment is for 20 months. So that is the background regimen. Depending on the resistance pattern, you are going to change the medication. Yes. So exclusion criteria for shorter regimen. Exclusion means if this is present, you cannot give shorter regimen. Exclusion criteria. RR-TB means rifampicin resistant TB. Okay. RR, see here, RR means rifampicin resistant TB. RR, rifampicin resistant. See, again there is actually no logic in this. All this is a combination of drugs. Now you can understand how tough it is to treat TB bacilli. RR means rifampicin resistant. So you just once sit down before exam, you go through this table. So these are the regimens as of now available in our country, available worldwide. Bedaquiline is available in our country. Then coming to the last part, rapid fire approach. Now in emergency department, there is a patient with shortness of breath. Tell me your diagnosis. So a patient with shortness of breath and pleuritic chest pain, hemoptysis, unilateral swollen leg. So chest pain, hemoptysis, unilateral swollen leg can be due to DVT. If there is DVT with bad presentation, think of pulmonary embolism. Pre-XDR is MDR resistant to fluoroquinolones. Then pleuritic chest pain, unilateral absent breath sounds, think of pneumothorax. In the emergency department, chest pain, shortness of breath, there is absent breath sounds, and if they give you hypotension, your answer should be tension pneumothorax. Next step, putting a needle and saving the life of the patient. Then pleuritic chest pain, fever, cough, think of pneumonia, pericarditis. So if there is typically fever, think of pneumonia. Then there is shortness of breath in emergency department, chest tightness, cough and wheeze. Common is asthma exacerbation. If the patient is elderly and smoker, think of COPD exacerbation. See here, with swollen leg, chest pain, pulmonary embolism, absent breath sounds, pneumothorax, fever, pneumonia, chest tightness, cough, wheeze, asthma exacerbation, it can be COPD exacerbation if patient is elderly, smoker. Then in emergency department, young female with shortness of breath, chest tightness, corpopedal spasm and anxiety. So there is spasm, tetany. It can be due to hypocalcemia. Psychogenic hyperventilation. Usually responsible is respiratory alkalosis. So any alkalosis can cause it, but generally seen with respiratory alkalosis. So in a normal individual, what happens here is albumin is having H plus and calcium. Now in alkalosis, what will happen is H plus is reduced. So H plus are decreasing. Now all these sites will remain free. So to these sites, calcium will come and bind. Because calcium is binding to albumin, within the blood, free calcium will reduce. So you can see here, lot of calcium, because H plus has reduced, lot of calcium will start finding that place. It will start binding to albumin. So because calcium from the circulation is binding to albumin, because H plus are lost. So there will be a transient hypocalcemia resulting in corpopedal spasm. Then central chest pain with crepitations with shortness of breath in emergency department. Rule out pulmonary edema, myocardial infarction. Rule out pulmonary edema, myocardial infarction. Then in the emergency department, shortness of breath, associated features, diabetic vomiting. If there is diabetic and vomiting, think of DKA. Pre-existing renal disease. Now presenting with shortness of breath in the emergency department with high BP and decreased urine output, think of renal failure. Patient must have gone into renal failure. Now there is hemoptysis, hematuria, renal failure. What is this combination? This is involving both lungs and also kidneys. So this is a pulmonary renal syndrome. So can you name few pulmonary renal syndrome? 3 I want. Goodpasture syndrome. Then connective tissue disorders such as SLE, and small vessel vasculitis such as Wegener's granulomatosis, pulmonary renal syndrome. So with this, as the clock ticks 8:20, I am going to say good night to you. So I hope we have made a journey from this type of gun. I have expanded your horizons and I made a gun which will make you to shoot more. So that's all, folks. So let the credits run. Thank you so much. It was great experience interacting with you all. Okay. Wait. There is some post-credit scene also waiting for you. So don't ever compromise on your dreams. Because why is it important for boys to get into post-graduation? So this is my trademark statement. MBBS degree will give you pride. But it is PG degree that will get you good bride, and brides are changing every year. So run after brides, get that pride, get into postgraduate degree. Thank you and good night, students. And it was a great pleasure. You can connect me on all this. Thank you for the patient listening. I thoroughly enjoyed this experience. Thank you. All the best. All the best. So come over. We'll have Jack Daniels. Good night, students. Thank you.